Thanks everybody for being here. You can see some agenda items that we're going to go through, just updates and then some dashboard metrics. I'm going to talk a little bit about senior life solutions, construction registration area that we're doing, and then recruitment, financials, and then a little bit about patient volumes, each time, a little update on market adjustments that are going to be coming out, and then kind of a theme that we want to talk about this year in 2017, make it easy. So a little bit around our dashboard, our leader reports. Remember, exceptional work environment. This is really about keeping us safe, keeping our staff safe, really reducing the costs that we spend on employee injuries because we are safe. If employees are safe, they're at work, they have better lifestyles, don't have the injuries, and those types of things. So important. Not that we don't want to spend the money when we need to, but what we really want to do is reduce injuries. I mean, that's why a lot of talk about the ice out there right now, the salt and sand shakers, to remind you to be careful when you're walking anywhere right now. I know people are using them at home, in the driveways as well, because it's just a lot of ice. The other one is really around days cash on hand, making sure we've got the money in the bank to do the things that we need to do, i.e. pay us. That's always important, I know. Also to work with capital that allows us to be able to get the capital items that we want. You know, usually 10,000, 20,000. X-ray is usually really good about large ticket numbers and stuff like that, but allow us to continue to keep up with the equipment that we need to give the services that we want. And then the other one around patient care, wait times. This is a combination of a wait question that's in 4 different surveys. So we really track that. Right now we're on an uptick. I think the in size so far, since we're about halfway through January, is pretty low in size, but in the right direction. So it's really making sure we're taking care of our patients, not making them wait, or if they have to wait, they understand why they're waiting, keeping them updated, keeping them informed. Then our healthy community, that's really around the work around diabetic patients with A1Cs. Even though we know things are going to change in the future, how we get paid, how we don't get paid, depending on what happens at the end of the month with the new Congress, new president, really it's about keeping people healthy. And then that's what this is. You know, if we can keep people healthy, if we keep diabetics with their A1Cs under 8, that means they're managing their diabetes. They're not showing up in the ER. They're not a train wreck. They're not having, you know, bigger problems and those types of things. So really working with the health coach, the discussions around how do we improve that. And then the other is really our operating margin. You can't see it's in dark blue, so it's hard to see here, but right now we should be at a positive 56,000, and we're at a negative from budget 480,000. So we'll talk a little bit about that when we get to the financial part, but definitely not where we want to be with our operating margin. We'll have some further discussion of what we think we can do and ask of each of us to improve that. So Senior Life Solutions, we've talked about this, but I want to remind people the reason for doing this. If you think about in our business, there's 1 or 2 things you can do. You can increase revenue or decrease expenses. And those of us in the room, we're the biggest expense that we have in healthcare. Our staff is the biggest expense. So instead of cutting that, how do we increase our revenues? And one of the things that we're doing is bringing Senior Life Solutions. And as you can see, they're a large hospital-based geriatric outpatient psych group. They'll be here. They employ 3 people. We employ 3 people that you'll see. You'll see them in the north area. And they focus really on care, compliance, and then working with the community and helping people understand how to serve that group. And it's really around Medicare patients, so our elderly people, really around you know, those that find their different life changes that are happening. Maybe grandma's died and grandpa's having some, you know, depression, trying to work through that, or they've sold the farm and moved to the nursing facility. Life's changed for them, and some of those changes are tough. And so the nice thing about this is they don't need a referral. There can be referrals if a physician sees somebody and says, oh, you know what, you might benefit from this. That can happen. But if you have a grandparent or a friend or something that's this age, you can say, why don't you stop in? And they can walk in, that group will do the evaluation. If it's something that they aren't able to do, they can send on to other resources, so to Mason City or different resources that we have. So it's a neat program that we can offer. The other part is it's a Medicare program, so that helps us on our cost report. Also, we know with our nursing facility and our assisted living that are attached that we have a need even in our organization for this. So more to come about that. They hope to be up and running, seeing the first patient the first part of March. We'll see that happening. So any questions around that? So the other area that we're doing construction is up front. If you remember, we at one time had this big room about this size that had all of our patient records in it for our clinic. And so now that we've gone to electronic medical record, we had that space. And we had looked at it for about 6 months, really trying to figure out what do we do with that space. And when we started out, we wanted to look at 8 different goals we wanted to achieve. You see patient privacy. How do we make it more private for people when they're registering? We've come a long way. Remember, you used to stand in the hallway with the big garage door that rolled up, and you'd stand there in the hallway and tell people why you were there to see the provider. We were able to move that around the corner, so it was a little bit quieter, a little bit more private, but we wanted to do even more privacy, and that's why we'll have the 4 different bays that they'll be able to work in. And then our pod coordinators really had some, every once in a while when it's really busy in the clinic, a lot of noise in that area, a lot of hubbub. They're right in the middle of everything. So trying to move them so that they have a little bit less noise. Then our health coach, for now probably over a year, we've had them kind of stuck in the facility break room. And that was temporary. We wanted to be able to move them out and have their own space. But then nursing space, when all of our providers are here, we run out of a place, one spot for a nurse, so we have a nurse that's kind of camping out wherever they could find a place, not very advantageous. And then we've got a couple exam rooms that what we've done is, you know, we've got our clinic manager and what could be an exam room, and then we have supplies in an exam room, and we wanted to open those up and free those up, especially when we're able to hire another provider and be fully staffed, we would need those. And then another, we were, as far as nursing space, you know, Tracy shares a room with a mid-level provider. It's not conducive for either one of them. So now we'll be able to have her own space to be able to work in. And then centralized registration. As we went to electronic medical record, a registration is a registration is a registration, no matter where it's done. So we have the ability to register people for any of our services at any of our sites or any of our spots, unlike where we used to have to do it in certain areas. So, and then as we said, we really wanted to be able to give the facility break room back and then move the health coach and the navigator out of that area. So let me pause there. Any questions around those? They are, as of this morning, on schedule for this area and SLS, Senior Life Solution area, which is amazing because we had a pretty aggressive timeline, and a lot of the issues really were just as soon as the contractors knew what we needed for a lot of the air conditioning and heating and cooling, ordering the parts and getting the parts here was even a pretty fast turnaround. So pretty happy with this still being on target. So around recruitment, we continue to recruit for a full-time physician. Lee Albert and I continue to vet those, and a lot of discussion, a lot of work. We get a lot of names possible. We do some calling back, find out if they're really interested. Some of it's interesting because the physician is, I'm interested in anywhere. And then so then you follow up and say, well, do you have snow there? Yeah, so I'm not interested. So a lot of those, trying to vet those through and really trying to find out if people are as interested or if they're just really fishing to see what's out there. And then the other part, Allie, as you know, I think she's doing her clinicals today. She's with Dr. Laufer. She'll be done and practicing as a mid-level provider in the winter of 2017. So about this time next year, she'll be coming on board and seeing patients. So we're excited about having kind of our own homegrown person that we've supported and worked through, and will be practicing here with us. The other thing that we've started looking at too, as we looked at schedules, we really started to learn that, you know, we start the day with the openings, but we were ending the day with openings as well. And so we started tracking, and for just a little over a month now, we've been tracking how many openings we have at the end of the day. And we had just over 200 openings in December. Now some of those are cancellations and some of them are other things, but if you look at that and if you fill those openings, that's almost a mid-level in itself. So we've got a lot of opportunity that we can do to see patients even currently without adding another provider. What we're working on is, one, we started with tracking it, so we actually knew some numbers. We thought there were openings, but we weren't sure. Then the other is really start looking at what are the barriers and to filling those positions or those openings. You know, one barrier is, if you look at right now, anyone that's on call, that first on-call slot is very seldom filled. Because by the time somebody calls, that's a pretty quick turnaround. They're not able to do that. So then there'll be discussion around, do we fill that with something else? If it's Dr. Hansen that's on call, do you fill that with a regular visit to fill that slot? Or do we start answering the phone early? None of this we've decided, but it was a barrier that we learned that pretty much that opening never gets filled. So how do we look at that? So that's part of the things we're looking at. And how do we address when people call and want to try to get in? What are we doing? How are we working through that? So a lot of work that's being done to try to capture even those 200 plus in a month. You know, if you only do 100 of them times 12, it's 1,200 visits. So we can take and add a lot of visits just doing that in itself before we even bring on another provider. So right now, Lee's doing a nice job. He's reporting that at huddles, talking about what we start the day with, what we end the day with. So I think we're doing that because there's a perception that we have no openings. You know, people will say, well, you don't have anybody that can see me. And what we're learning is, yes, there are. And how do we get people to use those and those types of things? So a lot of work to be done around that, working on the perception of, you know, no appointments. Yes, if you're calling and you want to see Dr. Lawford tomorrow at 10 o'clock and no other time, yeah, probably not going to get in if you're going to start being that specific, you know. But if you call and say, you know, I want to see anybody, how do we get that person in and what are the barriers? So a lot of work around that. We continue to press forward just as much, if not more than what we have in the past, on trying to get another full-time physician as well. So this won't negate any of that. It's just really a quicker turnaround and something we can start doing now and taking care of the patients that we have. Any questions around that?
I think that's a really good thing to bring up and work on, just because coming from ER, a lot of the patients, that's some of the frustration that we hear is, well, I tried to get in at the clinic, but I couldn't.
Right.
And so that's nice to see that.
No, that's good because...
It doesn't always go that way, because some people we send down, not all, some people we send down because they're having some
Symptoms that need to be managed by ER.
Yeah.
Sure, absolutely.
Yeah, there's an opportunity for both. One is, yeah, if somebody shows up and has chest pains, that's where they're going to go. That only makes sense. If you got somebody that has a cold, you know, you don't want somebody that has a cold going through the ER. It's just not good uses of resources. But then on the other side, how do we make sure that we've got the ability to take care of them? So, yep, a lot of good conversations around it. So financials, I want to talk a little bit about how we ended our fiscal year 16. The end of fiscal 16 would have been the end of June. We did have a positive operating and total margin. If you remember, we went through this thing of electronic medical record conversion. Part of that and part of what the government did is had meaningful use dollars. Now you had to prove that you were using the system, not just putting it in and then doing everything on paper, but you had to prove that you were doing it, hit some metrics and those types of things. And we did receive about $2.1 million. I can tell you that didn't cover the cost of the electronic medical record totally, and it didn't cover the cost of training, filling for those that were getting trained, but it's there to help offset some of that cost. So we did get that. That doesn't really help our operating margin, but it helps us in cash flow. And we'll talk about that a little bit further on. Days cash on hand, we ended up higher than what we had budgeted. We were the only one out of the 6 facilities that went live on the Cerner Community Works that didn't suffer in this area, as well as in days accounts receivable. A lot of them shot up double this and even higher. Some of them had to bring in companies to help fix that. Some of them brought companies in and it didn't help, so they spent the money and didn't see their accounts receivable days go down or their cash go on hand. Actually, it went down because they paid the contractors money. So a lot of great work. The thing to remember about all this is now, in the world that we live in, all of that starts day one. When you do a registration, that's the beginning of it. And when we've talked to Cerner, I've had the opportunity to work with Cerner one-on-one, and also some folks that are going into Cerner and starting using Community Works. The thing that we've talked about is, I wish we would have known, it really starts at registration. That's the most important, getting that information. That row back there deals with what happens when it doesn't. You know, if you don't have the right thing, yes, all of us. So, and it starts there and all the way through. So I had talked with the board, and they asked me, well, who's really responsible for this? All of us.
Not everybody.
All of us have to be, yeah. Because if you're not checking the charges, it doesn't matter that the registration was done right. So all of it, yeah, from the beginning to the end, it does take everybody to do that. So congratulations.
Or if you don't charge a piece of equipment or a supply that we use.
Right, and then that doesn't get charged, and then you don't get the financial benefit of that. So good analogy. The other part is we've seen our average age of plant. You want this to be low, not high, so that means that you're not in an old building, you're in a newer building. Of course, what we've done here over the past 6 years has helped bring that down. What we're doing now with Senior Life Solutions, and then also with the registration area, helps bring that down. The average is about 10 years. What you don't want is that to creep up, which then means you got an old facility that you're not keeping up to date, not spending any money on. Now the other thing is you don't want this to be really low and have no money. So I mean there's an offset, and there's a nice mix of where you want to be. So any questions on fiscal 16? So let's talk about fiscal 17. Starting in July, I think most of you know our volumes have been under budget. It's really, if you think about it, most of it's right here. Volumes, volume, volumes, volumes. Volumes offset everything. If you have volumes, if you have services, if you're using them, that speaks tremendous to a budget. We've been able to bring our expenses down, but not to the extent that our volumes have been down. And we've known that, and everyone's done a great job of doing that and cutting them and being careful with that and those types of things. But you can see, as we talked about on the other slide, year to date we're about $536,000 off of budget. So below where we were last year at this time. And we'll talk a little bit about what we think we can do and what we can ask of you to help do. Now the other thing is, the good thing is, we still have cash in the bank. We're still able to pay our bills. You know, there's other facilities that are having the same issue, and they don't have the days of cash in hand. You know, and they're concerned about making those payments or their bond payments, those types of things. But that hasn't been an issue, fortunately, for us, because our cash on hand is good, and our days in AR continue to be below what or better than the gold standard that our accountant talks about. So it's put us in a nice place to be able to weather volumes being under budget. There's a lot of facilities that started with low cash on hand and then high days in AR, so the money wasn't getting in the bank, and volumes that dropped, and that's even a worse combination. So what can we do? What can we do, each one of us? Each one, I think, each time, and really what we're talking about there is each interaction you have, whether it's on the phone, walking down the hallway, any services you're giving, Each one of those, remembering how important that person is, trying to make that service happen, make sure we get that person in, making sure we're treating them like you would your parents, your loved ones, and making sure that that's something that they experience that they're going to tell their friends. Remember, everyone's quick to talk about, they'll tell 10 people if something goes wrong, they only tell one if it goes well. So we've got to have a lot of good ones to make up for that. But you know, it's really each one of us, even if you don't deal with the patient, but you're walking, you know, you're not at the bedside with the patient, you're not putting them in a room, you're not taking care of that patient, you don't have hands-on. What is that interaction that you have when you're on the phone with them or walking down the hall, you see them? All of us have those types of opportunities to interact with. It's really just talking about marketing our services. How do we market them? When we're on the phone, are we saying, oh yeah, you can never get in? Okay, that might be true, but is that the message we want to send? How do we talk about maybe making that so it doesn't happen? You know, or, oh yeah, he never does that. Or, you know, we spend a ton of money in marketing. What I find is it doesn't take long before one phone call just wipes out all that marketing that we do. You know, we can say, come here, get the service, but then when they have an interaction with somebody, if it's not the right way, it can go the wrong way. And then use the facility, and I got a little passionate about that this morning. We have people, and I don't know who they are, I don't care, I don't try to find out, but we have people that don't even use our own facility. And that's, I understand there's reasons for that. You know, when I was in retail, I worked for Pomida. I didn't go to Target to shop. My kids didn't appreciate that because they grew up wearing Pomida stuff, and my oldest still reminds me of that. What's even worse though is we have people that work for us and they go across town to our competitor. And then even worse is they have our insurance, so we have to pay for them to go to our competitor. So think about that. And there's a lot of reasons people might do this, and I understand that, and people want to be comfortable with who they go through. I know all the reasons, but it's interesting that when I have discussions with people, oh, I didn't even think about that. They don't understand the money leaving here to go somewhere else doesn't benefit us. In fact, it doesn't even benefit this county, because that money is going out of this county. It's actually going to Wright County, it won't be here. So use our facility, help us figure out how people want to use our facility and make it good experiences. I know that people have had great experiences here. I've had great experiences, my family's had great experiences. How do we make sure everyone has great experiences, whether they're the public or whether they're our employees? And that's how we do that, and that's how we win. You know, if you talk about the economy of Iowa, the fastest way to improve the economy of Iowa is if we put a wall up between Iowa and Minnesota and keep the billions of dollars that go across the border to Mayo. Mm-hmm. Whether we get them, Mercy gets them, Des Moines gets them, that would increase substantially the economy in Iowa. So those are some things to think of. Plus, when you go there to Mayo, nothing against them. My parents loved them. They went there. They lived in Minnesota. It costs you a premium because they don't negotiate, you know, and they don't really care because that's who they are, you know. I'm not saying they don't have good services, that I wouldn't send a loved one there if that was necessary, but. So.
One very interesting thing that I found out with like the University of Iowa services, mm-hmm. when I went and got my ears checked the last time, and they were talking about like a cochlear implant, yeah. And that, we were just tossing around ideas. They said, my audiologist, who is Stu Trembeth, and mm-hmm. all them that come here, hearing associates, yeah. They said that the leader in that technology and all of those medical services and stuff for hearing related things, yeah. is the University of Iowa, mm-hmm. far beyond what yeah. Mayo has already. Yeah. And I don't think that people realize that, hey, right. we have a university in Iowa yeah. that really does good yeah. things.
Yeah, I mean, they really, you know, there are instances of that all over in the U.S. or in Iowa, so good example. So each time, It's not trying to take the whole elephant. It's not trying to change everybody one day, but each time you have an interaction, making sure that that interaction is a positive one and making sure that it's as easy as possible. So let's talk a little bit here. It's a little bit hard to see, but this year we really want to talk about how do we make it easy. So how do we make it easy for our patients? Healthcare is very much regulatory. There's a lot of things we have to do, a lot of red tape, but a lot of time we add on to that, or it's something that we did 15 years ago. We're still doing it today because someone told us, but we're really not using it. So how do we make it easier? Because in all reality, here's a line, long line of people, and here's one that there is no line in. Where would you want to shop at? A or B? A or B? Yeah. So where there's no line, where you don't have to wait, where it's easy. So how do we make it easier? You know, another thing is, you know, quite often we have patients that come in, and this is a little bit of exaggeration, but not much. Yes, we need you to check in. Can you fill all these out? Or do we want to say, can you fill this out? You know, now the upside is if they fill these all out, they can get a referral for carpal tunnel, and maybe we can get that surgery here, but it's really not making it easy. So how do we make it from this to where there's a lot of work, a lot of steps, a lot of questions, to something that's much easier for them? And I'm not saying we want to bypass regulatory things or quality. Well, let's be smart about that. You know, we've had examples of where people have called, can I get this? No. And we've gone back and said, okay, what are the barriers? And we've reduced those barriers, and they were able to get those services. But how many of those do we not even hear about, you know? And so how do we find out what are those barriers? You know, if you're on the phone, you're talking with people, and they're calling for this service, and like, no, I can't do that. No, we can't do that. You need to be jotting that down and saying, here's the barriers. Or, you know, love to come in, but I can't see anybody. You know, I can't get there until 6. Well, you know, this week I had 12 people call and say, I'd like to have been there, but I can't get there until 6. So what are those types of things that are out there? What are we hearing? What are the reasons for the times that we can't say yes to them? So 2017, the focus is going to be making it easier for our patients. Might not always be easier for us. Might mean that we have to do some energy, spend some energy to figure out how to get rid of those barriers, how to make sure that people are going to be here, how are we going to make sure that we cover the things that we need to. So most of the time it'll probably be more work than saying, no, can't do it. But in the long run, sustainability for all of us, it's even better, and it's better service. We don't have to send them somewhere else to have that service. So some of the things we're going to do, and there's a line list, I just picked a few of them. Monthly, our electronic medical record, health record strategy group meets. We're going to morph that into not just talking about changes that we need, but also talking about changes that we want to make it easier. Been on electronic medical record now for a year and a half. How do we use that to make things easier for us? How do we use that versus it using us? And then departments are going to be reporting at Facility Huddle things that they've done to make things easier. So you're going to start seeing this theme. Anybody see any difference on your screensavers? Yeah. So if you've updated or refreshed your computer, the screensavers now are talking about how do you make it easier. You'll see more and more of that. Nicole's doing some work on kind of an internal campaign of what this looks like and how we have this discussion. So the departments are going to report at Facility Huddles. You're going to be talking about it at your huddles in time. Each leader in our organization is going to be responsible for so many changes to make it easier for patients. And then the service pillar, we let that sunset a little bit when we introduced and implemented Cerner Community Works. That's going to be revived, and we're really going to start working on their focus, how to make it easier. And leaders are going to be talking about that. So trying to make it as easy as possible for people to get their services. Try to reduce the steps, reduce the paperwork, reduce the hassles, reduce the time to get answers back, those types of things. Let me pause there. Anything around make it easy?
Is there a spot, like, if I get feedback from a patient for whatever, I'll tell Stephanie,
Mhm.
of course. Is there somewhere that if we hear a patient's comment, that we can put that information somewhere?
Sure,
Or
no.
just continue to report it?
I'd say continue to report it to her, and then she brings it up. But in time, we might look at something on the drive where you could put those. But yeah, good question. Other thoughts? Let's talk a little bit about market adjustments. Vicki does a lot of work around this. We use what's called the Iowa Hospital Association survey each year. She sits down. There's 5 parts of this, different areas. Virtually goes through every job that we have and looks to see where people are within that, that scope. And then from that, we make recommendations of, okay, we've dropped a little bit behind here because the market, for some reason, nursing continues to be a tough market. Lab used to be, different departments, coders when ICD-10 was coming. So you see the market have a little hiccup and increase because of those types of things. So we want to address those. And then she and I review the market. We spend about a half a day looking at that. And then after we've tweaked that, we take it to the personnel committee, have them look at it. And then from that, they take it to the board of trustees and make a recommendation. Even though our financials, when they looked at this last month, weren't where they needed to be, they made a commitment to go ahead and move forward with the market adjustment. Those that have received one will get it in the first check, full check in January. This will be January 26th check. When you see that, when you get that, you'll get a note so you know that. Remember again, it's market driven, so not everybody gets one. It's not a given. It just depends on what the market's doing and where they're seeing increases within the market for those types of adjustments.
Is that going to be in the email? Because now it's all automatic, or all emailed.
Yeah, there'll be, you'll get it, yeah. And then there's an email actually that'll go out that explains this process. Those of you that have been here a while have seen that. I think there's like 4 slides that she's used before. That'll go out again this week, just reminding people of that whole process. So a little bit deeper dive than what I gave you here. So some celebrations, market adjustments. The board recommended to go ahead and do that, even where we were in financials. You can hold those. Unfortunately, you still in some time have to do that. So it's pay me now or pay me later, and so they wanted to continue to move forward with those. Senior Life Solutions, just another way of adding new revenue to our system. We're also, the nice thing about Senior Life Solutions, we took that storage area, and I know a lot of people were involved with that, Megan and her group. So, that was costing us money to have that. When you put it on our cost report, we lose money having that storage area. So just changing that from storage to Senior Life Solution helps us on the cost report, much less the fact that it's also a Medicare product, and will help us as well. So construction, we continue to change with our space, utilize it even better to meet our patients' needs. Apple Valley Partnership, if you remember, Apple Valley now manages our assisted living. They are full. They have 2 couples that are up in Clear Lake that are waiting to get in here. So we've kind of got a backlog with that. The other thing, Allie will be starting in the winter of 2017. That's exciting. And then our Wellness Center partnership. We've partnered with a Wellness Center. They're on our campus. Want to continue to work with them, keep them viable, and in the community to help the community stay healthy. So, any other we just celebrated this week, and I forgot this morning, 270 years worth of service. We had our annual recognition So 270 years. So that's not including the ones that that are above 30 and 35 and 40 that were on, like, you know, not the even days or the odd, you know, the 35s, the 30s. I think, like Sharon's been here how long now? 30, 40, yeah, 43. So, so that wasn't even including those. So a lot of people been here, and I think that's a celebration itself. You don't see that now. I mean, the average is 5 years. You know, 5, 10 years. It's pretty much, especially with the millenniums, the younger ones, they can up and move and go wherever they want pretty quickly, and they do. So let me pause there. Any questions? Probably in summary, what I would ask is, you know, our volumes are down. Be conscious of that. Realize that anything that we can do to get people in, whether you're the one that's on the phone scheduling or if you're on the one that's talking to somebody about using our services, we are all, I know Nicole does a great job on marketing, but I can tell you our marketing is in this room and how we interact with people when we're working, when we're not working, when we talk about the facility, those types of things, the message that we send. And sometimes even we don't realize how we send it or what we're saying, you know, and so just kind of thinking about those types of things and supporting the facility as it is. We've got a lot of things to celebrate, a lot of great service, a lot of things that we've done and accomplished and are continuing to move forward and accomplish as well. So, questions?